Just to see if this is worthwhile reading. Have we had this one before? Watch puppy videos online. This is definitely good. I think we have kitties.
My whole testimony.
Amazing.
Come right up. It would be funny if somebody else
Like
did
the
that.
audience.
So let us go live. Calista. You're live. Terrific. So we are Senate Health and Welfare. It is Wednesday, March 25th. We're marching along, really amazing. And we're picking up 611 with some testimony. We did a sort of quick walk through with Ledge Council, and now we'll have a chance to hear folks' comments. I know some of you have, at least one person has a proposal to bring to us, and we may or may not get to that today. So this may or may not be the last day to hear testimony, but I'm thinking that from what I understand, we'll be able to move through the bill fairly expeditiously and hopefully get it out sooner than later. So we have Maria Rossi, who is a doula social worker, Washington County Mental Health. Maria.
I'm right there.
Oh, I know you.
She was over there.
Yeah, that's what I thought. Okay. Please come up. Come on up.
Thank you.
And do we have for everyone, do you have your testimony online? It's very helpful to us. So as we go along, just send it in to Celesta. That would be good. Okay, welcome.
Thank you. Thank you for allowing me this time to talk with you all today. My name is Maria Rossi. I've been a doula for about 15 years, and I'm also a social worker. As you said, I work for Washington County Mental Health, and I coordinate a doula program out of that agency that I helped to develop almost 14 years ago. I'm here today providing testimony on behalf of the Doula Association of Vermont, or DAV, a statewide group that I co-founded. I was here last year when this committee took up the doula bill, and it's nice to see some of our doula champions, as we like to call you, and it's also a pleasure to meet some new senators, and I appreciate the opportunity to provide you with some information about this bill in doula care in Vermont. Doula care is an evidence-based, cost-effective service that is unfortunately out of reach for many, if not most, of Vermont families, especially those who stand to benefit the most. We see Medicaid coverage not just as a way to improve outcomes for children and families, but also as a way to increase health equity in our state. Doulas are trained individuals who offer non-medical, non-clinical, interpersonal support to birthing families. Doula care is emotional, often mental health support. Care is provided before, during, and or after childbirth. Over 40 years of studies show that doula care leads to a 30% reduced risk in labor inductions, a 28% reduced risk in unnecessary cesareans, a 14% reduced risk in newborn admission into the NICU, and a growing body of evidence is showing the doula's role in mitigating perinatal mental health outcomes. Nationally, doulas have received bipartisan support, and currently over half the states have enacted Medicaid coverage. All but 4 states are in some place in the process of implementation. 3 states have submitted state plan amendments in the last year alone and are now covering doula care, and that would be Pennsylvania, South Dakota, and Utah. By the end of 2026, we expect that our neighboring states, New York, Massachusetts, and New Hampshire, will all offer Medicaid coverage, and Maine is not far behind as well. We've come quite a long way in the process. Over the last 2 legislative sessions, incredible work has gone into a thoughtful and thorough process for implementing Act 50. OPR, as directed by Act 50, has worked to develop the professionalization of doulas who would like to provide Medicaid services. They worked collaboratively with DIVA, DAV, the doula community, and other stakeholders to develop draft regulations. OPR is working diligently with DIVA to ensure their rules align with federal CMS guidelines. We support the regulatory solution proposed by DUA of obtaining a referral for doula services to ensure reimbursement for Medicaid approved doulas in Vermont is consistent with CMS criteria. As we understand it, this referral could come from a range of licensed clinicians, including OBs, midwives, and social workers. We remain committed to the further professionalization of doulas in Vermont, as well as supporting both the doula community and families to access and engage this service. We also understand that this clinical touch point is something that every state has had to contend with in their way. DAV supports the recent work of OPR and DIVA to work collaboratively with the doula community and find a path forward to bring services to Vermont Medicaid birthing families in a timely way. We support the process that has resulted in a path forward for the SPA for doula services. While questions remain about the details, we are satisfied with the language in H611 to support successful and timely implementation. I'm confident that as a state, we want to do all we can to support young families in Vermont. Ensuring they have access to doula services would improve health and mental health outcomes for birthing individuals and their babies, as well as provide cost savings to Vermont's healthcare system by reducing rates of perinatal mood disorders, cesarean births, and NICU stays. Dr. John Kendall, a pediatrician and researcher, once said, if a doula were a drug, it would be unethical not to use it. Let's not further delay providing access to this critical service to more Vermont families. I'm happy to answer any questions.
So in the bill itself, do you have a comment about any specific section of the bill?
We support the bill as it's
Okay.
great.
That's all I wanted to know. That's great. Thank you. And thanks for all the data, because I know there's an increased interest at the hospital level for utilizing doulas more frequently.
Yeah, the hospitals, we're really lucky in Vermont. The hospitals have a very collaborative approach to welcoming doulas into the space.
Good. Thank you.
Thank you.
Thank you very much. And who's next? Make Fisher.
Good morning.
Good morning.
Mike Fisher, healthcare advocate, and we also support the bill at draft.
This is what we love to hear. So we'll go through the bill more closely with markup and put our own fingerprints on it, maybe or maybe not, but it's really great to know.
Just a little bit of the history over on the House side. We did bring a couple of proposals to the House side, one of which we became convinced after talking to Diva didn't make sense. And so we withdrew it, one of which I believe is now your section 6 in this bill.
Section 6.
Yeah, it is just a technical cleanup. This was language that has been there for some years, but never actually implemented, never actually practiced about B-Farm eligibility. Again, we support the bill as was teaching from the House. And then I'll also say, while we were not directly involved in the doula discussion in the upstairs, we watched it, and I watched it, and thought that it represented good compromise work between the various parties, and to get a good outcome.
Terrific. Thank you.
Good.
And so in section 6, can you just explain what this relates to? This is Quimby?
This is, I believe, B-Farm.
Oh, it's beef. Oh,
Yeah.
Oh, 32. Okay.
And so I believe that this language here that's crossed off has been in statute for a long time.
Okay.
And it is not how eligibility is calculated. And so it is just cleanup language.
Okay. Good. Thank you. Thanks. Any questions, committee? Thank you.
Thank you.
So, just a technical bill, we could put some technical corrections. Alex McCracken, come on up. Diva. And Abby is not here, that's okay. Welcome.
Good morning. Thank you for having me. It's wonderful to be here. Hold on, I go from my computer. I have some slides that I will share for the committee, and I will walk through the bill as written section by section.
Are we gonna be able to get these slides on our
They
webpage?
should already be with you.
Okay, I'll refresh.
If not, I'm happy to send them over.
Yep, we got 'em.
Okay, perfect. Is that coming through? All right, wonderful. For the record, my name is Alex McCracken. I use she, her pronouns, and I'm the Director of Communications and Legislative Affairs for the Department of Vermont Health Access. It's wonderful to be back with you all. I have very fond memories of being in this committee as a committee assistant years ago, and it's wonderful to see some new members join as well. So thank you for having me. And I will walk through each section of the housekeeping items we put forward in H611, explain why these changes are being proposed, and we will certainly have time for questions and discussions. If there are questions, feel free to interrupt me as we're at the section. I don't mind. We can have it more of a conversation.
Can I have one quick question?
Please.
Before you get started? So will Ashley Berliner also be testifying, relative to Lisa? or-
So I have our colleagues from AHS policy, AHS Medicaid
Oh,
policy.
you're right here.
They're right here.
Okay.
They
we're
will,
good.
they will jump in,
Okay.
with anything that needs clarifying, and they're also here to talk about the doula section in more detail.
Excellent, thank you.
Okay, so starting with section 1, this section repeals an unnecessary pharmacy reporting requirement. This was brought to us by the Diva Pharmacy team. The current statute requires Diva Pharmacy to annually construct 2 lists of drugs experiencing larger than normal drug price increases. This information is then sent to the Attorney General's office for their drug transparency reporting. The most recent report from the Attorney General's office concluded that the information supplied by Diva is unhelpful because Diva is federally prohibited from sharing drug-specific net cost information. So it's confusing, it's opaque, it doesn't help them for their purposes of reporting. So we would propose that we repeal the statutory requirement for Diva to provide that data to ease the administrative burden of our pharmacy staff.
And I understand the AG's office has found it not useful to have this data, so.
Correct. Section 2 is a section repealing 340B discrimination language that was passed as part of H266 or Act 55 last year. This language was added by the House, and Diva has no issue with repealing this language.
Okay, and I think there'll be other comments on the 340B stuff.
Section 3 provides technical updates to the Medicaid Exchange Advisory Committee, or the MEAC. Recently, the federal government promulgated rules that change a state's obligation around the Medicaid advisory committees. We have recently instituted the Beneficiary Advisory Committee, or the BAC, which serves alongside the MEAC as a sister committee. So we propose updating the statutory language around the MEAC to reflect the new federal rules as well as the existence of the Beneficiary Advisory Committee. Okay. Section 4 is a change on the definition of reflective health plans. When we passed Act 2 in 2025, it's separated or unmerged the individual and small group health insurance markets in perpetuity. They were already unmerged, but that clarified that there was no sunset on that. And we should have had a technical fix that removed references to reflective plans. Now that the small group market is separate from the individual market, small employers and their employees don't need reflective plans since small group coverage doesn't offer federal subsidies, and the loaded premium issue only affects individual market plans sold on the exchange. That's a lot to say. We should be clarifying that reflective plan definitions are that reflective plans are for the individual market only.
So this, we've heard about this one ongoing, and it will also be, I think, important for finance to get it, to take a look as the bill goes along. Yeah.
And somebody would please refresh my memory on what a reflective plan is. I honestly.
I so wish Hattie were here for this question.
Right.
Okay.
I can provide you a more wholesome definition once I have an opportunity to create one.
Great,
Yeah.
thank you.
So
Thank you.
we will look at that.
Yes, but we will get you that answer.
Mhm.
Uh, unless anyone from,
Oh, I think,
Mike Fisher.
Mike Fisher.
My chopping.
I don't mind if Mike wants to answer.
Not at all.
It is a near identical with just with the smallest possible difference between it and the non-reflective plans in order to be able to grade those plans separately.
no.
That really helped.
That didn't help me at all. I'm sorry.
So what we'll go through and we'll get a very strong definition.
We
for
can
this.
send a summary to
Yeah,
the
would be
committee that we can
Yeah.
provide.
Thank you for trying.
I know finance has looked at this recently. We have not looked at this recently, but it's important for us to understand what's here
Absolutely.
as we get to move it. Go ahead. Go ahead.
So section 5 changes CURB membership requirements. The CURB is the Clinical Utilization Review Board. And this was a request that came from the CURB, which is a body of medical professionals and clinical professionals who advise the DIVA clinical unit on coverage matters as well as clinical matters. So they have come to us with the request that the current statutory language, which caps their membership at 10, be amended to allow for flexibility. So change the language to say a minimum of 10 members rather than just 10. They believe this will allow for greater flexibility with membership to serve staggered terms, as well as encourage greater diversity and participation in the current.
And this is going to be important as we move along with changes to primary care.
Yes, we appreciate the work that the PERC does, and they serve a very vital function. Section 6 removes MAGI methodology from VFARM statute. This is what the healthcare advocate referenced earlier. This is a technical cleanup. We have never used MAGI to calculate VFARM eligibility, so it is removing language that is not being used.
That's section 6. Yeah, that we just talked about. So that's.
Section 7 is an increase to the burial fund limits. This is certain funds can get set aside to cover future burial costs and be excluded from Medicaid financial eligibility. So the current limit is 10,000, and that has not been changed since it was put into statute in 2002. So it's been a very long time since we've increased the amount of eligibility or amount that can be excluded from Medicaid eligibility. The proposed solution in H611 would increase that cap to 15,000, implementing a use of a Medicaid payback requirement. And the current $10,000 cap would continue to apply to other burial fund arrangements, such as designated savings account.
Yeah, go ahead.
We have consulted with OPR on the implementation of this to ensure that funeral directors that they regulate are able to take advantage of this change. And we've also been in communication with the Vermont Funeral Directors Association.
So how would the payment go? Because we did hear about this in appropriations. So where does the money come from for these burial payments?
Well, this is money that people can set aside for future costs around burial, and that's excluded then from their Medicaid eligibility.
Was there an earlier discussion in this bill, or perhaps it was in the proposal in the appropriations, to have the money come from the funeral directors? That's not going to come.
No, that's
different.
So
And I feel comfortable saying that in our conversations with the funeral directors.
Cemetery.
That's what you're dealing with.
I
That's
got
saying that.
There's a lot swirling around in here about cemeteries, dead people and funeral directors. So
You really need that happiness day, Saturday.
that's why we have the little puppies.
No, to be clear, the Funeral Directors Association has signaled support for this.
Okay, that's good.
Alex, is there a definition for what burial is? Does this include cremation and green burials and things like that?
I believe it does. I would want to double check with the Funeral Directors Association, but I believe that it would cover various methods.
Okay.
I asked the same question.
But I will double check and follow up with you, Senator.
Okay,
Thank you.
that's good. Okay,
And the last section here, section 8, which you've heard a little bit about already, is the delay in Medicaid coverage for doula services. This is responding to Act 50, which requires AHS to begin pursuing a state plan amendment for doula coverage by July of 26, which is this year. The department supports covering doulas, but we have significant concerns remaining around CMS approval for coverage and the potential for federal scrutiny. We have worked very closely with our colleagues at OPR and BDH in the doula provider community and with the advocate community to come to a solution that works for all parties. And we very much appreciate that collaborative effort from all sides to ensure that we can provide coverage for doula services in the future. So the proposal is to push back the date to seek a state plan amendment to July of 27, which would create more runway to properly implement. I would also note here, there is a slight language change that will be needed from the House version. This was brought to our attention from OPR that their section also needs to be amended to be 27 rather than 26. So that is one small change that we would request on the current bill.
what, do you know where that is in the bill?
It's section 8, that's very
Oh,
close to
it's,
the
I
end.
see it, yeah.
It's the OPR specific language
So that would change to 27.
to match ours. Right.
Well, there's one thing we can do there. Yeah.
And I will also note that we're continuing discussions with OPR to ensure that the burial fund language in the previous section is doing what it needs to do. So we will follow up with the committee, hopefully later this week with confirmation that that language does not need to change.
Okay, that's helpful.
Yeah.
Thank you. Senator Wiley.
Yeah, could we go back to section 3, Alex? Sure. Just, I don't, just educate me a little bit on this, the federal government promulgated rules. I don't know what MEAC really is or does.
Yeah, absolutely. I'd be happy to speak to that. So the MEAC is an advisory committee made up of many different individuals from around the healthcare policy space, including the healthcare advocate and others who are in this room. And they advise the Commissioner of DIVA on policy as well as provide kind of an outside perspective on Medicaid and marketplace exchange activities. We're a little unique in Vermont because we do have that integrated system with DIVA, like the Medicaid Exchange Advisory Committee is not just the Medicaid Advisory Committee, so they do work on the ACA marketplace side of things as well. And then the federal rules are largely around the institution of the Beneficiary Advisory Committee, which is made up of entirely Medicaid members, current, former, or family members or caretakers of Medicaid members. And they then serve jointly either solely on the back or on the back and the MEAC. And then they can provide their advisory function to the DIVA commissioner. So this language change is really mostly about incorporating that new beneficiary advisory committee language into Vermont state statute because it's not currently there.
So these individuals are also probably gonna help with like primary care and figuring out some of those issues moving forward.
To the extent that Medicaid is involved
Right.
in changing the payment
Correct.
methodology.
Correct.
So there's also primary care work groups. There's also the blueprint. There's also the strategic plan primary care advisory committee. So there are a lot of groups feeding into that as 197.
Okay.
Yeah.
Sometimes too much is not good.
It is, it's, yeah, but it's, what's the good news about this, about that one, just going back to 197, is that everyone is really rowing in the same direction of interest. And there's some, DIVA knows the folks that they need to hear from so that they don't make cause a problem.
Thank you, Alex.
There's a lot going on.
And I would say again, the clinical utilization review board is probably more the primary care advisory committee for DIVA. But anything that crosses into the.
I'm just seeing the Medicaid portion of this, which is going to tie to some degree into one of these.
So, and I'm just looking across the room at Grace and Ashley and a lot of the that work, the payment work will be modeling. It will be left to you, I think.
But
Along with
the real pros, but
Yeah.
yeah.
Want to introduce yourself for the record? Did you want to come up and testify? Because I have questions, I will have questions for you.
Oh, okay. Sure.
Yeah. So are you good?
I'm good if you're good.
Okay.
Thank you so much.
Well, so we
Madam
debatable
Chair.
whether we're good, but if you, so,
Are any of us good?
we'll hear back from you on those couple things.
Thank you.
Wow. And I shot it.
That's a big news.
Oh, it's.
I'm gonna cut the arms off of your chair, so much times we can go underneath that.
Yeah, right.
What
Yeah.
we need is just tell David we're threatening to cut the arms off his chair. And
You can't
he
get around
finds us a new.
Yeah.
Yeah.
Oh.
That'll make it happen.
That will make it happen.
All right, so actually, thank you for being here. So why don't you go ahead with the testimony and then we'll.
For the record, Ashley Berliner, I'm the Director of Medicaid Policy for the Agency of Human Services. It's good to be here in person. I really don't have anything to add to the testimony that Alex already provided. We are very happy with the compromise that we were able to agree to in the House around the doula provision, and we'll be spending the next year working on the state plan amendment, moving that forward. Happy to answer any questions, and I also have Grace Johnson here, who's the policy subject matter expert on this.
So when you're talking about state plan amendment, you're talking about the 1115 waiver process.
No,
Others? What does
separate,
that mean?
yeah, so the state plan amendment, the state plan is essentially the contract between the Centers for Medicare and Medicaid Services and the state of Vermont. And it is the like who, what, when, where of the Medicaid program. So what services are provided, who's allowed to provide those services, and who are eligible for those services. That is all spelled out in detail in the state plan amendment. So whenever we add a new service, we have to amend our state plan. It is a approval process with CMS, where we have to go through a public notice process. So that will be posted for public notice. There'll be a comment period for anyone to provide comment on our state plan amendment. And then it gets submitted to CMS for their review and approval.
Yeah.
What's the timing on that application?
We plan to submit it next year in 2027,
What, so
springish,
about, which I didn't hear.
spring.
Spring. Oh, spring. So we like spring.
Yeah.
So we have time to think about everything that we hear from folks once you put out your information.
Yeah, so we are going to be starving because we have, as you know, IT issues. I don't know if you've heard of that, but
Oh.
just to remind you.
This is new.
So everything takes a while. So we're gonna begin starting that process this year, like
Yes.
setting up the service in the system, figuring out what rates look like, figuring out how we're gonna draft our state plan, and then in 2027, we will be submitting a SPA. It will be effective 7/1 for the legislation.
Sure. Right, a lot of work between now and then. IT, we would love to have IT not be a problem. Okay. So questions on the state plan process with it, and so the implications for the in this bill for state plan include.
We have to ask for a state plan amendment for CMS has to approve it. We don't think it will be controversial. It is a process. It is, an administrative slog to get through that. But we think as the first person who testified, Maria, spoke out, other states have this approved. We're not like out on a limb here. So we feel confident that we'll be able to get the state plan.
Amazing what we have to go through to help our constituents and citizens.
Madam Chair, are there other, I don't know if you can answer this, but are there other procedures or healthcare issues being brought up in the when you're looking at the Medicaid Sorry, I'm trying to get my thoughts through the state plan, thank you, or is it just the?
That's a great question. So what we do is we submit a specific page to CMS that is what they are supposed to review. If that page touches anything else in our Medicaid program, they have license to go explore that. So we try to structure it in a way to limit their purview as much as possible to the topic at hand. Sometimes we're not able to do that based on just the structure of our state plan. We've gotten more sophisticated as we've gone along, but if we touch old pages, it becomes harder to kind of narrow the scope. I don't know off the top of my head. I believe we would just do a brand new page here, so I don't anticipate any unnecessary investigation, but that's always a risk with the state plan.
Any other questions? But I have two questions that are related to Medicaid and whether you or Alex can answer them. It could be, bringing back questions. So where are we on Medicaid prior authorization? And that we still have prior authorization for primary care in the Medicaid program.
We do not have primary care prior authorization right now.
It's still, we haven't sunset that. It is still
We don't have primary care
prior.
auths. We have prior authorizations for a very limited set of services that we feel like need more utilization management, and primary care is not. Yeah,
That's correct.
yeah.
So, okay, that's all of them. That's one question. Okay. Then the other question is something that is coming up and is fairly new and that we're going to be hearing about on Friday, and that's long COVID and how long COVID is being handled within our public system. And then coverage of, you said certain drugs. So there are emerging drugs that we won't talk about. GLP-1, Wegovy, and that one with chemical, it's in clinical trial. So what conversation, if any, are you folks having? This is a broader question for Medicaid, and maybe it's the Medicaid Advisory Group Committee on long COVID, because it is new and it is devastating. And there are a lot of people in the state who are affected by it. So I don't know what you're seeing for that and the burden you're seeing both on patients and then on the services we're able to offer.
Yeah, I can't speak to the burden that we're seeing. We have pharmacists on staff that certainly are more plugged into that. We also have a drug utilization review board, similar to the clinical utilization review board, that looks at drugs and drug coverage. And so we can definitely set up conversation with the right people to talk more about.
So that's drugs, but then in terms of the primary care, I know that a lot of primary care docs are now becoming really knowledgeable about treatment and referral, because there's cardiovascular, there's pulmonary, there's all kinds of different consequences with long COVID. How so just curious about what the conversation might or might not be, but anything you can provide is something.
I'm not sure I can speak to any specifics, but I'm happy to follow up with some of the relevant folks in DIVA and see if we're seeing any impact.
Good, that'd be good. I know we have this rare diseases bill that we'll be looking at, the Rare Disease Advisory Council today. And but long COVID isn't a rare disease now. It's predominant, more like a lot of other chronic diseases. So not a question, just a question.
Yeah.
So not rhetorical, but, and thanks for being here and offering comments. Any other questions? Well, we have the director of Medicaid here, this person here, Medicaid policy. It's really important. And Grace, with that, also. Did you want to introduce yourself for the record, Grace?
Sure. My name is Grace Johnson. I work as a senior policy analyst on the Medicaid policy and at FHS.
So you've heard our questions. Anything can help us with?
I don't know anything more than action.
Okay.
Some truth.
No, it's not. Wow. This is too easy. Thank you very much. And I appreciate your coming in today.
Okay, it's gonna add some complexity here.
We need complexity. It's all the businesses. All right, well, unless there are other, we don't have other, did you want to comment, I've got 5 minutes left before S 46, age 46.
Sure.
Why don't you come up and offer your here?
Sure. For the record, Mary Kate Molman, Director of Vermont Public Policy with Bi-State Primary Care Association. We support our federally qualified health centers, our Vermont Free Referral Clinics, and Parenthood, which they're having a legislative day. Just want to flag that. I would like to call attention to section 2 of H 611. That is the repeal of the rebate. We don't love it, but given what's happening at the federal level, we're not gonna make a huge stink over it. It is a huge administrative burden and upfront cost for covered entities, but again, there are other things where we'd like to spend more of our political capital. So on that front, since we did open up Act 55, we would like to propose an amendment that would close a loophole that we did not unfortunately foresee when we first passed Act 55.
And Act 55 was.
Was
I know what it is.
a bill that included a lot of several protections for covered entities in the 340B program. Briefly, what the
So I'm sorry, we just passed the 340D bill last session. Right. I don't know if they're up to speed. Should we do a quick primer on what 340D?
I will do the 30-second 340B
Okay.
summary. I'm happy to also talk a little more offline or come back later.
And is this repealing what we did last year? Is that what this repealing?
So the repeal that is currently in 611 repeals the rebate program prohibition.
So first, let's go back to Senator Gulick's very good question for new
Yeah.
folks and a refresher. 340B is.
340B is a program that says for drug manufacturers to participate in Medicare and Medicaid and get that book of business. They need to provide drugs to safety net providers, so FQHCs, certain hospitals, Ryan White clinics, at a reduced price. Then when those drugs are prescribed and I speak for FQHCs, so when FQHCs then get reimbursed, they get reimbursed the full general reimbursement rate for that pharmacy. And so that savings, that differential between what they purchased the drug for and what they then get reimbursed for the drug is a savings that they can use to provide free dental care, different outreach, geriatric care, also reduce co-pays for pharmaceuticals for those that are struggling to pay their co-pays for pharmaceuticals. So it is a key program that allows federal entities to stretch their federal dollars further by having these reduced drug prices.
So what I'm going to suggest is that we'll come back to this. We'll have Ledge Council come in and talk a little bit about 340D, and then we'll have you come in and share with us your recommendation.
Okay.
That'd be good. But at least we got a look at concerns that you're bringing in from the community health centers.
Yes. Yes.
All right. Good.
Thank you.
Thank you. Great. So if you're sitting in a chair reserve, you need to get up. And
We'll move our crew out.
our Ledge Council needs to put her work down on the table. Like 81st. We're gonna move on to 6. So H611 we'll continue work on. I don't hear anyone that's not happy.
Yeah. So that's just a flat 340B stuff.
Yeah, good.
Yeah.
So. We moved you from last week to this week. Thank you for your understanding. Considering taking. This is good.
Yeah.
Thanks for being here.
Of course.
So, do you know everyone on our committee?
I don't think I've met.
We're going to introduce ourselves.
John Morley from Orleans District.
Thanks to me.
John Benson from Orange Business.
Two Johns. You John.
Yep.
I know.
Makes it easy, right?
Very easy, right? Jenny Lyons, Chittenden Southeast. Incoming. Yeah. So you cleared the room.
I know. A good thing or a bad thing?
Thank you for being here. Why don't you share with us, I know you're the reporter of the bill, and just give us the overlook of what's here and why it's important.
Sure. So we passed H46 out of our committee and in the House last year. And this is an act relating to the Rare Disease Advisory Council. It's a super simple bill with a lot of impact. Approximately 60,000 Vermonters, this will impact, who have a rare disease. So the bill establishes a Rare Disease Advisory Council in Vermont. Right now, we're the only state in New England that does not have one. Little background, a rare disease is a disease, disorder, illness, or condition that affects fewer than 200,000 Americans. Over 10,000 rare diseases affect more than 30 million Americans. According to the National Organization for Rare Disorders, approximately 1 in 10 Vermonters, or over 60,000, are living with a rare disease, which is a significant number, right? And
Yeah.
this advisory council will really help support that group of individuals. So Rare Disease Advisory Council, or RDAC in short, is an advisory body that gives this community a stronger voice in state government. They address the needs of rare disease patients and families by giving stakeholders an opportunity to raise awareness and make formal recommendations to state leaders on the most important issues that they face. There are thousands of known unique rare diseases, and it's difficult to have an in-depth understanding of the rare disease community's needs. So the RDACs use their diverse membership and broad community support to identify barriers and propose solutions to help the rare disease community. And then lack of awareness contributes to common and harmful obstacles that rare disease patients face, such as delays in diagnosis, misdiagnoses, lack of treatment options, high or out-of-pocket costs, and limited access to medical specialists. And this advisory council will really help educate this community and their families so they have they can overcome some of these obstacles. Right now, last year it was 29 states, and this year it's 33. I just looked it up before I came down. States that have enacted legislation to support their rare disease community. And proven that the RDAC can be an invaluable resource. And as I mentioned, Vermont's the only state in New England that does not have one. So this advisory committee will support the state in strategically identifying and addressing barriers that prevent individuals living with rare diseases from accessing adequate and effective treatment and care for the condition. It will be composed of the following members: 2 individuals with rare diseases, a parent or guardian of a person living with a rare disease, a commissioner of health or their designee, the Commissioner of Disabilities, Aging and Independent Living, or their designee, a representative of the Health Equity Advisory Commission, an academic researcher that has experience or conducts rare disease research, a physician, nurse, and pharmacist practicing in Vermont with experience treating rare diseases, and a geneticist or genetic counselor. And what they're going to do is convene public hearings, soliciting comments from individuals, providing testimony and comments on public legislation that impact this community, and consulting with experts to develop policies that identify conditions to recommend to the Newborn Screening Advisory Committee, and supporting timely patients' access to diagnostic services, treatment, and enhancing quality of services. They'll meet quarterly, and the Department of Health will support them administratively.
Thank you.
So it's super simple, but it really will have a huge impact on a large number of our
You know, the challenge here is there's so few people, they don't have a voice.
Yeah.
So this gives
This will give
voice
them a voice.
for people who need to be heard. What was the vote in your committee on this?
10-1-0.
10-1, yes. always more.
There's always one.
And the floor, was it, unanimous, yeah. Questions? For Representative Garofalo? Nope. We're good.
Great.
Thanks and
Thank
thanks
you
for
so
coming in.
much. Thank you for your
Being patient
consideration.
with our schedule.
Yeah.
Good. So Katie's gonna walk us through in detail, and then we'll move on to page 270.
Go back.
You may leave.
Oh.
You have.
Thank you.
Katie, thanks for being here.
No problem. Good morning. Can you let me in the room? Yeah, thank you. Katie Glenn, Office of Legislative Council. Good morning.
Good morning.
Okay, so I feel like Representative Garofano has already done my job for me. She gave me a lot of
I was
detail.
saying, okay.
Maybe you don't see me.
Why don't you just go through it all?
Okay.
You don't have to do it.
It is conceptually a very simple bill. It creates this council. There are some findings prior to getting into the creation of the council. The General Assembly finds that lack of awareness contributes to common and harmful obstacles that rare disease patients face, such as delays in diagnosis, misdiagnosis, lack of treatment options, high out-of-pocket costs, and limited access to medical specialists. And with the support of the National Organization for Rare Diseases, various patient organizations and stakeholders in the rare disease community, rare disease advisory councils, are enabling states to strategically identify and address barriers that prevent individuals living with rare disease from accessing adequate and effective treatment and care for their condition. So that is the findings. And then we create this new chapter for rare diseases. And in section 981, we're creating the council. So there's created the Rare Disease Advisory Council within the Department of Health to provide guidance and recommendations to the public, General Assembly, and other government agencies and departments as necessary regarding the needs of individuals living with rare diseases in Vermont. And then we list the members. 2 individuals living with a rare disease, at least one of whom is an older Vermonter, one appointed by the Speaker, one appointed by the Senate Committee on Committees. A parent or guardian of a person living with a rare disease appointed by the Committee on Committees, the Commissioner of Health or designee, a Commissioner of Dale or designee, representative of the Health Equity Advisory Commission.
There was spelling mistake.
Do I?
I believe it's this. That could be.
Oh, thank you. Okay, well, I guess we're gonna have an amendment.
That's gonna be an easy one, Dave.
Wait, well, I missed that.
There's a typo.
What did
That's a
it say?
script.
There's not.
Where is it?
Under E.
Third line, 13, Heath instead of
Equity. So
health.
health.
Oh, Heath, wow.
I don't know. I was just reading quick.
There's
Yeah.
Sorry.
That's okay. I'd rather know about them
I
than
wonder who did that.
me.
No. I was gonna say the editor did that.
No.
So somebody's gonna question what Heath is.
Yeah.
What I was thinking.
Yeah, Heath.
Okay. F, an academic researcher who conducts rare disease research appointed by the Speaker of the House. A physician practicing in Vermont with experience treating rare disease appointed by VMS. A nurse practicing in Vermont with experience treating a rare disease appointed by the Vermont chapter of the American Nurses Association. Top of page 3, a pharmacist practicing in Vermont appointed by the Senate Committee on Committees. And a geneticist or genetic counselor appointed by the State Senate Committee on Committees. Subdivision 2, this council shall collaborate with any other relevant stakeholders it deems appropriate, including the National Organization for Rare Disorders. In subsection C, this is the responsibilities of the council. So the council may conduct the following activities for the benefit of individuals impacted by rare disease in Vermont. So notice that's a may and not a shall. I just wanted to emphasize that. Convene public hearings and solicit comments from individuals impacted by rare diseases to assist the advisory council with creating a needs assessment, identifying gaps in services for individuals with a rare disease in Vermont and the needs of their caregivers and providers. And 2, provide testimony and comments on pending legislation and rules that impact Vermont's rare disease community before the General Assembly and other state agencies.
Was there any discussion about, or maybe it's later on, keep going.
Okay. Consult with experts on rare diseases to develop policy recommendations that identify conditions to recommend to the Newborn Screening Advisory Committee as part of the Vermont Newborn Screening Program. And top of page 4, that support timely patient access to diagnostic services and treatment and enhance quality of services provided by rare disease specialists. Maintain a webpage on the Department of Health's website to serve as a resource for individuals with a rare disease that contains notices of upcoming meetings, meeting minutes, public comments, and previous annual reports, and any other activities identified by a majority of the advisory council. The advisory council has the administrative, technical, and legal assistance of the Department of Health. Report as needed. The advisory council may submit any recommendations for legislative action to House Healthcare, Human Services, and Senate Health and Welfare. Meetings, the commissioner or designee shall call the first meeting. Annually, the advisory council shall select a member to serve as chair. The council shall meet quarterly. Meetings may be held in person or remotely on an electronic platform as determined by the chair. Majority of the membership constitutes a quorum. For reimbursement, members who are not otherwise compensated for their participation shall be entitled to per diem compensation and reimbursement for not more than 4 meetings annually. We have this taking effect on July 1 of 26.
Okay. I had a question. Go ahead.
How many total members are on this board? I didn't add them all. No, I can do it. I didn't know if you just knew like.
No,
just-
I don't.
No, it's good.
But notice this, A is 2.
Right.
Yeah.
And then the only other question was,
I just got 11.
11?
Yeah.
Okay. On the bottom of page 3, A, it says identify conditions to recommend the newborn screening advisory committee.
So you may want to hear more from the Department of Health. They have a screening program and they have a list of conditions that newborns are screened for right after delivery.
Okay, so it's before rare disease. Is that kind of what you're getting at here? This is kind of maybe before some rare diseases?
Sorry, it could be.
Okay, thank you.
There are some that are easily screened for with a little prick on the toe and get the blood and make them out.
Wow.
Yeah, I know, the little ones. Yeah. Wait, Senator Benson first, then Senator Collins.
So does the pharmacist have an organization?
Yes.
To do the appointing.
Yeah, I was curious why the
Why the-
pharmacist was being appointed by the committee on committees as opposed to the pharmacy organization appointing their own representatives.
You've run from.
Yeah, we could think about that. I mean, it could be the board of pharmacy or I don't know.
Now, there's a pharmacist.
There is.
A pharmacist from Rutland.
Right. That's an association.
And Theo Kennedy was the lobbyist representative.
So they have an equivalent to EMS.
I'm just thinking they may have a better idea of who the right person is than we would.
Yeah,
Yes.
we'd have to reach out to them to ask for suggestions. So maybe
Yes, some
look
of
at
these
that.
appointments by the committee on committees or the speaker for professionals.
Although I will say this, it's really important to have the legislative process involved in the selection. And try to be, sometimes you get it.
Okay.
We can talk about that.
I'm sorry to interrupt. I was trying to look through, I was wondering if there was Human Services worked on this last spring, so it's not entirely fresh in my mind, but I was trying to remember if there was some effort to try to have equal appointments from the House side and the Senate side, but it actually looks like there maybe are more Senate appointments than.
There are two on the Senate side, one on the House side, so.
I think there's more than that on the Senate side. I think there are four. So I can't.
I didn't say that. I didn't even hear it.
Senator Cummings had a question.
Yeah, I may have missed it, but is there a parent or caregiver on this
Yeah.
commission? Yeah, okay, all right, there it is. All right,
If they have time.
that's true.
Yeah.
Okay. Well, it will be interesting to get testimony on this and figure out what the rare diseases are in our state and, you know, the list of rare diseases. We'll figure that out. Is there anything else we need to know here?
I don't know. Nothing comes to mind.
Well, one thing that I do like is where they have the report as needed. I was gonna suggest one proposal of amendment would be as needed or upon request. Yeah,
Is it, I mean, isn't that the same thing?
well, that's they need to do or upon request
Okay.
from the legislature. That's the
We
thing.
call them in and ask them to tell us.
All you have to do is say, come give us an update.
That's
Yeah,
neat.
I don't know where we need to.
Well, you at least need to be clear that you want information.
Try to avoid a confrontation.
Oh my God, yeah, okay.
As needed suggests that the council is deciding when
That's
it's
what
necessary
I
upon
thought.
request ensures that the legislature is asking for information.
That's exactly what I
Thank you.
like. That's good. All right, so. Committee, shall we pick up this one, keep going on this one? I know. Okay, all right.
Yeah, will there be a fiscal note at some point? As there is there is already.
Yeah, and it did go through,
Because there is,
it was passed last year, so it
Yeah.
must have gone through last year's budget.
okay,
So now it's gonna have to go through,
Well, no, it wouldn't have, because they worked on it after crossover, no,
Oh,
it
that's
didn't
right.
make crossover.
okay, yeah. So it'll go through the budget process this year. It's
What
pretty
was-
minimal.
What was this?
The per diem,
Yeah, just at the very end, the per diem to pay the.
yeah,
the
they
committee.
just stick
Yeah.
out. It'll be
Any price
a
to-
tiny.
Eventually they do you.
Nolan might tell you that
I
it
didn't know
could
that.
come out of the,
Yeah, they all per diems.
Nolan might tell you that it could come out of the departments, like it's
Budget.
de minimis. I have to see how many of the professionals or how many people aren't showing up in their professional capacity. So 2 individuals, 1 parent. Everyone else would seem to be showing up in a professional capacity.
That is de minimis.
Unanimous.
Minimus.
Okay, so Mary, are you here for 270?
No, I was nosy because this is my bill. that I've been
46.
Shepherding for,
So-
yeah. So I just wanted to hear.
Oh, okay, well, we're gonna keep working on it. Good job.
I think so too. Okay,
All right,
I gotta go to the floor, but I was like.
well,
this
we
now-
we'll, I know that we have a bill that you're thinking about on baby food, so we'll have you into that.
Yeah.
Yeah, I'll basically just be living here. then.
Oh. Okay, a nice addition.
Okay,
Cool,
thank you.
Bye.
thank you. All right. So why don't we move to H 270 and see what that one is? Okay, we could try and finish a little bit early.
Okay,
We're on the floor at 10:30.
should I jump in? I didn't know if you had somebody from the house come in for 270.
Who's the reporter on this? This supposed to be in H 270. Well, we got them in. We'll have them in regardless.
What's the thanking for copies? The hard copies. Appreciate it.
Okay, so this is H 270 and act relating to confidentiality and peer support sessions for emergency service providers. So this maybe I should back up a little bit. A couple of years ago, there was a bill creating an advisory council for emergency. Yeah, for emergency service providers, recognizing that there's at times a lot of traumatic incidents that could impact their mental health. And this I think is an offspring of that. And this is that there are sort of in-house, often peer-to-peer support sessions for emergency service providers. Maybe to debrief after a certain incident. Sometimes it's individuals who are on staff who are trained to lead these peer-to-peer programs. Other times, a department might contract for the services of entities that do this. So this creates confidentiality for the communications that happen during those peer-to-peer programs. Human service, no, this is in healthcare. Healthcare, there was a lot of conversation about who was doing these services. And you'll sort of see where they landed, that it is not necessarily somebody who's certified as a peer support provider to do that. So they created their own term of emergency service peer support provider to distinguish from somebody who might be certified in doing this, acting in this role. So one thing to keep in mind as you look through this. So who is an emergency service provider? A long list, somebody currently recognized as a Vermont fire, by a Vermont Fire Department as a firefighter, a person currently licensed by the Department of Health as an emergency medical technician, an emergency medical responder, an advanced emergency medical technician or paramedic, somebody who is certified as a law enforcement officer by the Vermont Criminal Justice Council, including constables and sheriffs, an individual who's currently employed by DOC as a probation, parole, or correctional facility officer, an individual currently certified by the Vermont Enhanced 911 Board as a 911 call taker or employed as an emergency communications dispatcher providing service for an emergency service provider organization, an individual currently registered as a ski patroller in a Vermont ski resort with the National Ski Patrol or Professional Ski Patrol Association, an individual currently working as a mental health professional in a crisis setting who is licensed, certified, rostered respectively to provide mental health services as a physician, APRN, and specializing in psychiatric mental health, psychologist, a peer support provider, peer support recovery specialist, social worker, alcohol and drug abuse counselor, clinical mental health counselor, marriage and family therapist, psychoanalyst, applied behavior analyst, or anyone who is non-licensed or non-certified psychotherapist, non-certified psychotherapist, or any other profession that provides mental health services.
Would probably be easier to list who isn't. That's a huge list.
So these are all individuals who, the qualifier is that they're working as a mental health professional in a crisis setting. So this isn't a person who's operating a practice. This is somebody who's maybe going out with a police officer to respond to an incident. And somebody who's currently serving as a medical examiner or assistant medical examiner as appointed by the chief medical examiner. We have a definition of employer, means an entity that employs or oversees an emergency service provider who's working in a paid or volunteer capacity. We have definition of what we mean by a peer support communication. That means oral or written communication made in the course of a peer support session, a note or report arising out of a peer support session, or a record of a peer support session. Peer support program means the program to provide services to emergency service providers. Peer support session means an individual or group session by a peer support specialist for emergency service providers who have been involved in a potentially traumatizing event or suffering from cumulative or chronic emotional stress by reason of their employment or volunteer service or related to other personal matters. So just note that 4 is like the overarching program, 5 is the individual session where the peer support is happening. And then we have a definition of emergency service peer support specialist. This means an individual who has been designated by an employer to serve as a member of an employer-based peer support program, or designated by a peer support program to act as a peer support resource. Somebody who has received training to provide peer support to emergency service providers who have been involved in potentially traumatizing events by reason of their employment or volunteer service, or as otherwise a member of an organized or recognized Vermont peer support program. So any of those criteria, and the person would be considered an emergency service peer support specialist.
Doesn't have to be everybody in an organization. It could be one peer support specialist.
It is not requiring that each department has a peer support specialist. This is just saying, to the extent that these peer support counseling sessions are happening, this is what we mean by peer support counsel. I shouldn't say counseling. This is what we mean by peer support session, and confidentiality attaches. Got it. Yeah. Page 4. Emergency peer support specialist shall not be construed to have the same meaning as a certified peer support provider, because we know when you worked on that bill several years ago that a certified peer support provider it has a special meeting. There's a special certification program that's approved through OPR with particular clinical standards. So this is somebody different. Okay. Subsection B1, except as provided in D, any peer support communication made by a participant in a peer support session of a peer support program led by an emergency service support specialist shall not be disclosed by any individual participating in the peer support session. So that is the sort of the rule, and then there are some exceptions. And B, any peer support communication relating to a peer support session led by an emergency service peer support specialist between the specialist and another staff member of the program, or between staff members of a peer support program, shall not be disclosed by any individual participating in the peer support communication. Under 2, written peer support communications are exempt from public inspection under the Public Records Act. They shall be kept confidential. The Public Records Act exemptions created in this section shall not be subject to the repeal provisions of the PRA Act. So there's an automatic review to repeal PRA exemptions, and this would not be subject to it.
Now, do you know if GovOps, we'll have, when the reporter comes in, we'll ask this question, but did GovOps look at this section in the House? Or?
I did not go to GovOps.
Okay. But the bill didn't go there. And so
I would think the bill didn't go there.
But
maybe they informally looked at it.
That's what I was.
I wasn't in the room.
We'll find
That
out.
could be. Okay, except as provided in D, any peer support communications made by a participant or emergency service peer support specialist during the support session led by the specialist shall not be admissible in a judicial, administrative, or arbitration proceeding, including during any discovery conducted as part of the adjudicatory proceeding. Limitations on disclosure imposed by this subsection shall not include knowledge acquired by an emergency service provider from observations made during the course of employment or volunteer service, or information acquired by the emergency service provider during the course of employment or volunteer service that are otherwise subject to discovery or introduction into evidence. So what does that mean? So that means, while comments and communication made during the peer support session are not discoverable as part of a judicial proceeding, if there is, let's say, you are an emergency service provider and you are observing just in your day-to-day work that somebody's behavior is becoming more erratic. And maybe you learn during the peer-to-peer session that that person is struggling with a substance use disorder. You probably wouldn't be able to say anything about what you've heard in the peer support session, but your observations that the individual's behavior have become more erratic could potentially be disclosed in a judicial setting if they're otherwise discoverable. It could be there are other bars to that information being shared. So we had lots of language that's provided in D. So here we go with our exceptions. Confidentiality protections described up above in B and C shall not apply to the following information as it pertains to individuals designated to receive such information in the normal course of the individual's professional responsibilities. So this is information that that can be disclosed. Any threat of suicide or homicide made by a participant of a peer support session, or any information conveyed in a peer support session relating to a threat of suicide or homicide. Any information relating to the abuse of a child or vulnerable adult, or other information that is required to be reported by law. Any admission of conduct likely to pose a risk to public safety. Any admission of a plan to commit a crime. So if those are disclosed during a peer support session, those are items, those are topics that could be disclosed to the appropriate person in the person's organization.
But it doesn't impose a mandatory reporting requirement, simply that it could be.
It just says that the confidentiality shall not apply.
Got it.
Yeah. Top of page 6, nothing in this section shall prohibit any communications between specialists regarding a peer support session or between a specialist and another staff member of the peer support program. So basically 2 support specialists can have communications with each other. A specialist and somebody who's otherwise staffing the peer support program have communications with each other, even if both parties were in the same session. In subdivision B, an emergency service provider specialist or an emergency service provider participating in a peer support session from disclosing personal experiences or emotions discussed during the peer support session to the extent that such disclosure is consistent with the participant's obligations under HIPAA and its associated regulations. So this is language that healthcare sort of added and had a larger discussion on. This is saying that if the provider was in a peer support session and they maybe talked about an incident that had caused trauma to them, this doesn't prevent them from sharing their experience or their emotions surrounding that experience with somebody else because they're talking about themselves, as long as what they're saying doesn't contain HIPAA protected data. So, you know, if it was about a certain person and it's identifiable, that would be a problem. But if they're saying, I responded to a call and it really went badly and it's, you know, like that could be disclosed to another person, even though they already disclosed it in their session. In subsection E, an employer, emergency service support specialist, or peer support program is not subject to civil liability for any injuries, damages arising from the provision of the services or for any disclosure made in violation of this section by an emergency service provider who participates in the session, unless the conduct of the employer, support specialist, or program constitutes gross negligence, recklessness, or intentional misconduct.
Wow, yeah, so I think the genesis of this bill goes back to the remember that committee we had that is like 30 people? And it was I forgot the name of it, but it was a request on the part of emergency responders.
Was
We need help in our PTSD, our concerns about the work we're doing. And then the next bill, which was the last session, I heard from folks in my community that we don't know how to respond when we're in an emergency situation and help people. So then we put some language into the emergency guidelines through the Department of Mental Health, and they've been working on that. And now we have this, which I think is really a good place to go. Sounds like it's a good place to go with peer support. There's a lot in here. We need to hear from the reporter of the bill and what transpired. So we have just Senator Morley and then Senator Cummings.
I was just wondering because like our fire personnel and ambulatory services, there's policies and that are in play here within, so that if an event of traumatic event does occur, that there's services available to that individual already. Something's driving this.
Yeah,
Sounds like
that's it. It's that we need support when we respond to something difficult and we need someone to talk with.
I'm surprised they're not getting it now. That's surprising.
They may be getting it, but they may not be getting it in a trained. They don't have people who really understand how to deal with people who have these types of problems. So they have to have some skills in interviewing and communicating that don't exacerbate whatever the problem the person's going through.
Could I just issue a clarification? So this doesn't require any type of programming. So if this isn't weighing in that all departments have to have some type of peer-to-peer program.
That
This
makes
is saying when there is a program, you have this confidentiality protection.
Okay.
As long as, you know, these guardrails are met.
That is going ahead. Thank you.
Thank you.
Senator Cummings.
this, we joke about committee, we went through the alphabet, but it was because more and more groups wanted to be involved. It grew out of a grant. Cornelius Hogan.
And the
Yeah,
former
Captain
commissioner of
Lee.
DOC.
Yeah, he was a state police officer, chief in Rutland, ended up as head of DOC or head of corrections. And he got this, it's a couple $1,000 Con Hogan Public Service Award. And he wanted to do something because he was very concerned about police officers. That was his, but all public emergency personnel. The thing that brought a lot of people out was there was a dryer fire in Essex and like a family of 4 died. And they said the volunteer people got there and you're dealing with dead kids. Here it was the Barry Fire Department who had 4 children die on Christmas Eve from smoke inhalation. Heart-wrenching, you know, they had to go home the next morning and deal with their kids, and they fought with it because now, why didn't smoke alarms go off? There were smoke alarms, so you now have to have photovoltaic smoke alarms because they're more sensitive to smoke than heat, and the smoke kills you before the fire does. We heard from a lobbyist who was an EMT, and she said, you know, at least if you're a firefighter, police officer, you go back and you hang out with the guys. And she said, you're an EMT, you go through some awful things. And you go back the next day and you're in the state house and no one knows. And there's no one to talk to about what you saw. So this group is supposed to
Help each other.
help set up programs to make sure that these folks get the counseling. If you have a full-time unionized fire department, you usually have something.
Very rare.
But if you're, if you're a volunteer,
But in the volunteer and rural parts of the state, or even in my district, those are the ones that had the
Yeah.
biggest concerns. And I want to let Senator,
well, I just said we should hear from them.
oh, we will.
I can jump.
We're just, this is
I
our
could
first
never
track.
done
Yeah. I've read
Did you have a question,
the
Senator?
whole department resigned.
So Senator Gulick has a question, then we want to wrap.
Well, I need to add to the list of folks. included,
Oh,
but
no.
in places like Burlington, and I don't know about some of the other larger cities, but we have folks like the downtown ambassadors,
Right.
and we have repairs teams.
Yeah,
I wonder if they should be included.
but yeah, we'll ask that.
Okay.
It's a good question.
Just the general.
Well, yeah, we'll hear from the reporter. We need to hear from the reporter because there's a lot here that gives us the.
I give you plenty of stories with one.
I got
You don't wanna
stories. We all have stories. We're gonna, what we're gonna do is we're going to,
Young child.
hold it. What we're going to do
I
is we're going to wrap for the day because we need to get up onto the floor and then we'll come back